Hello, welcome to AETCM. I am Kalyani, a final year medical student. This is Dr. Girish. This is our volunteer, Karthik. This is our EMT staff, these two. Today we'll be showing you or demonstrating you a case of seizures and how to manage a seizure after the seizure activity has subsided.
Can we start now?
Yes, sir, we can start the
So
case.
2 minutes back, this boy had a seizure.
Okay.
So it was witnessed by his friends and he
Okay.
was taken to emergency room.
Okay.
Now at present he is not having any seizure.
Okay.
So you can start.
Okay. So I would like him to be connected to the monitor.
So please connect to the monitor.
And since he had a previous seizure history, I would like to have the rails kept up so that the patient
Keep
doesn't
the
roll off
rails
the
up
bed.
so that he will not fall down. So we have kept it like that.
So for post-ictal management of seizure, we will follow the A to E methodology. So first we have to assess his airway. So for that, I'll have to check his oral cavity for any secretions. So since I see some secretions, I would like to have him in the left lateral position.
Okay, so please keep the patient in left lateral position. So we have kept the patient in left lateral position. His oxygen saturation is only 80%.
Yes, sir. So along with the left lateral position, I would also like to have the nurse put a suction cannula next to him in case we need to aspirate any secretions.
So you can start suctioning.
Okay, start suction.
Along with that,
saturation is 80%.
yes. So along with that, we'll have to put the NRBM mask at 10 to 15 liters per minute oxygen flow.
Okay, please start oxygen. Good. What else you want to know?
Oxygen is started.
Started.
Yes, sir. So the next step in the methodology is B, that is breathing. So I have to check if there is bilateral entry of oxygen on both sides.
Auscultate.
So I'd like to auscultate him.
So bilateral air entry is good.
Yes, sir.
There are no crepitations at present.
Yes, sir. So can I please have his oxygen saturation
Oxygen
at the moment?
saturation now it is improved 96%.
Okay, sir. So we can go to the next step, that is C for circulation.
Circulation is BP is good. BP is normal. Pulse
Okay.
rate is 98 beats regular.
Okay.
And 141/91 is the BP.
Okay. So since he has a history of seizure, I would like to have 2 large bore IV cannulas.
Please,
In case he develops a seizure, we can immediately provide medication to him.
2 large bore IV cannulas secured.
So since the patient has started seizing right now, I'd
Okay.
like to have IV lorazepam 4 milligrams immediately
So keep
given
the
to him.
patient straight. Hold it. Slightly hold. Start your chest.
IV lorazepam started.
Okay, sir. We'll wait for the patient. If the seizure stops, then this medication is enough. If he continues to seize,
He is continuing to seize.
okay, so if the duration is more than 5 minutes, we'll have to repeat. We have to do another dose of IV levetiracetam.
Dose.
IV levetiracetam, we have to give it at 20 milligram per kg body
so you
weight.
start 20 mg per kg body weight. Around 1 gram you start. In which?
In normal saline, sir.
In normal saline. Add in normal saline and start.
Levetiracetam 20 milligrams in IV NS started.
We have given it, but
Okay.
there is no change.
Okay.
So-
Maybe we can start phenytoin, sir.
So you can start phenytoin. What is the dose?
Not sure, sir.
Okay. So you give 20 milligram per kg body weight phenytoin in normal saline again.
20 mg per kg phenytoin is given in normal saline.
Okay. We'll wait. Okay, it's coming. Coming down.
Okay, sir.
Now the seizure activity has come down. What else you want to see?
So next step is to check his disability. So I'd like to know his GCS score, sir.
Okay. GCS is still low, but he is able to open his eyes. He is confused little bit.
Okay, sir. So actually, any patient that presents with seizure activity, we have to check for his GRBS levels.
Okay, again check the GRBS. He had one more seizure so that he can check the GRBS.
GRBS is checked.
What is the value?
GRVs is normal.
Normal.
So it's
Blood
not a
sugars are normal.
hypoglycemia causing seizure.
Okay.
Sir, along with this, since he had a seizure episode at home, I would like to see if there is any sort of injury to his body.
Okay,
So,
just check for any trauma to the body. Check everywhere,
so,
including cervical spine.
so while doing this procedure, we need to make sure that the patient is only adequately exposed and warmth is always maintained.
So they have checked it. There is no major injury. Minor abrasions are there.
Okay, sir. So as we conduct the A to E method, concurrently we'll also have to send a battery of tests. This includes,
investigation you want?
I would like to, so blood sugar is
Blood
already
sugar
taken.
is normal. Both
Yes.
first and
Second
time
one
it
is
was normal.
So we'll have to go with an LFT, RFT, a toxicology screen, and to rule out any heart pathologies, I would also like to have an ECG.
Okay.
And since seizure activity originates from the brain, so we need to see if there is any structural abnormality that might be triggering a seizure or any
Everything
stroke.
is done. All blood investigation, whatever you told, it is already done. Everything is normal.
Okay. So now the next step would be to take a detailed history from the patient's
Okay.
family. So the patient, the person who witnessed the seizure, can you explain of how the seizure activity looked like?
Seizure activated suddenly. He fell down and he had seizing episode, and after that he was taken to ER.
Okay.
His friends were observing this.
Okay, sir. So was there any eye rolling up, frothing
Eye-rolling
in the
was
mouth?
there, frothing was there.
Did he bite his tongue?
No, he didn't bite.
Okay, sir. Is he a known epileptic?
He is a non-epileptic.
Does he take his doses regularly?
Not exactly. He has missed a few doses in the last
doses.
2-3 days.
Okay, sir. So this could probably be the reason why he is having a seizure activity now due to the missed epileptic dose. So that
Okay.
concludes the major.
So this patient has recovered. Now oxygen saturation is good. Can we remove the mask now? So can we remove?
Yes.
Okay, so we are removing the
Oxygen
mask.
supply disconnected.
Are you all right now?
Yes.
He's all right now. He's better with your treatment.
Yes, sir.
Can you explain what is status epilepticus?
Yes, sir. So when any seizure activity that lasts for more than 5 minutes or when there is recurrent seizures without a break in between,
Okay.
we call that as a status epilepticus.
Okay. So what are the reasons? He is a non-epileptic patient. What are the reasons which had triggered this episode?
So mostly in epileptic patients, due to their missed medication is one of the
Here
most
it is
common
because
reasons.
of the missing
Yes.
tablets.
Yes.
Then
Other than that, it could be stress, lack of sleep,
Okay.
skipping food or meals.
Okay. Flickering lights,
flickering,
like TV
yes.
screen, flickering
Yes,
lights.
sir.
The most important reason is always the lack of sleep.
Yes, sir.
Okay, that we have to take the history, whether he had any episodes like that. Okay. Now, in a patient who had come with seizing activity, you have checked the blood sugar. What is the reason for that?
So most commonly, hypoglycemia is the reason for seizure
Hypoglycemia
activity.
is one of the reasons
One of
for
the reason.
seizure.
Yes,
and
sir.
what will happen to the blood sugar after seizing?
I believe it will go down.
It can go down because you are continuously using your muscles.
Yes,
Okay, so it can go down after the seizing episode. Here, fortunately, it has not gone down.
Okay.
But it can the seizing activity can be due to the hypoglycemia. Seizure itself is a cause for the hypoglycemia.
Okay.
Can hyperglycemia cause seizures?
Yes, it can.
Hyperglycemia also can induce seizures. That's why blood sugar is the most important investigation what we do here.
Okay.
Now you had asked for many blood tests.
Yes.
Okay. So in that one of that important tests is drug levels.
Yes.
Okay. You had asked to take the blood for sampling various blood tests, but one test you missed is blood levels for drugs.
Okay.
That is very important because all these phenytoin, phosphenotoin, phenobarbital, they all got a very narrow therapeutic index. You know what is narrow therapeutic index?
Yes, so the duration of activity is...
Narrow therapeutic index means if it goes high, it will become toxic.
Okay.
If it goes down, it will become inadequate.
Okay.
It is very, very narrow. So you have to maintain in that therapeutic index, then only you'll have benefit because of that drug. Okay. So that we have to do. And you have to ask for some electrolyte. Which are the electrolytes are most important in a seizing patient?
sodium.
Sodium hyponatremia is one of the reasons.
Yes, sir.
Okay. Then other conditions? Hypercalcemia, hypocalcemia, hypomagnesemia, all these conditions can produce seizing activity.
Okay.
Okay. So what other investigation you are asking in this patient other than that? Any blood test you want to check? Important things. I am not asking all tests. you have to always rule out an infection. So you'll be asking
Yes.
complete blood count, CRP, procalcitonin, all these things, and you have to do neck stiffness, whether the patient is having any meningitis, encephalitis or not. Can you check it now?
For neck stiffness, yes. Can you please elevate your head?
Neck stiffness will be done by the doctor.
Okay.
So you have to slowly flex the neck and see whether any neck stiffness. Can you do it?
Yes.
So slowly flex the neck. There is
there
no
any
neck
pain?
stiffness. So that means he is not having meningitis. So infection of the CNS is another important cause for any seizure. That includes first time seizure.
Okay.
So should we do an MRI or CT in this patient?
So usually for new onset seizures is what MRI is
Okay.
given.
So in a new onset seizure, you have to always go for an imaging study. An existing patient who is having seizure for many years, it is not required.
Okay.
Now we'll discuss about acute management.
Okay,
So you had started lorazepam as a first line drug.
Yes, sir.
Okay. So what are the other drugs which can be tried in this type of patients?
So levetiracetam
No,
can
that is second choice of drug.
Okay,
First choice is always benzodiazepine.
Yes.
In that lorazepam is the most commonly used drug.
Yes.
What are the other choices?
We can do rectal diazepam
Diazepam
in local
can be
hospitals.
given. Then these are mainly used in children. Rectal diazepam.
Yes, sir.
Any other things? Midazolam nasal spray.
Okay.
Same like children. Like you are unable to put a line. Okay, you give midazolam nasal spray or rectal diazepam.
Okay.
Lorazepam is very easily available. You have tried that. Okay. Now you have used a second line drug. Second line means we have on the line we have 1, 2, 3, 4 like that in
Yes.
the treatment plan. First is benzodiazepine. Second one is
levetiracetam.
levetiracetam. Many guidelines say you can either use phenytoin, phosphonatoin, but levetiracetam is one of the important drug in the treatment plan because levetiracetam can be used in almost all types of seizures.
Yes.
Okay, like patient who is having liver disease, can you use phenytoin, phosphonatoin?
No, sir.
It is not.
Yes.
It cannot be tried because it itself can produce liver damage.
Okay.
So there also you can use levetiracetam. That is the advantage of levetiracetam. And if you take phenytoin, phosphonatoin, how do you give phenytoin?
So in normal saline as IV.
So phenytoin should be given in normal saline.
Yes,
Okay.
sir.
But if you have a situation like patient is having hypoglycemia with seizures, patient is having seizures. On top of that, patient developed during the second time you check the blood sugar. That time suppose it is low. What do? You have to give dextrose. So phenytoin when you are giving, you have to give dextrose in a different line. But phosphonatoin,
we can give it in the same line.
it can be tried in phosphonatoin can be diluted in DNS also. So the phenytoin, phosphonatoin, the difference is clinically it is one is it can be diluted in NS only, phenytoin. Phosphonatoin can be diluted both in NS and DNS. How fast you can give phenytoin?
Slowly.
It can
Comparatively.
be given slowly
phosphonatoin.
when we are comparing with the
Phosphonatoin.
Phosphonatoin you can give in 30 minutes, the other one you can give in 45 minutes.
Okay.
So in a patient who is having continuous seizures, phosphonatoin will be always better. Okay. And side effect profile wise also, phosphonatoin is always better than phenytoin. Levetiracetam, it has got lot of advantages. It can be used in liver disease, lot of bone marrow suppressions, everywhere you can use it.
Okay.
If suppose these two drugs fail, you'll have to start. Fortunately, this patient, it was subsided with the second drug. If these two lines fails, you have to use the third line. What is the third line?
IV midazolam.
Midazolam, continuous infusion can be given. Before that, one more drug is there. Phenobarbital. Phenobarbital can be tried. The same dose. You can just remember 20 milligram per kg body weight.
Okay.
So phenytoin, phosphonatoin, levetiracetam. Small difference is there, 16 to 20 milligram. But if you remember 20 milligram, it's okay. Okay. So for phenobarbital also can be tried. Okay. If the patient still have seizure, then you have to paralyze the patient, intubate the patient, put him on ventilator. Why we are doing all these things? Why we are worried about seizure?
Can cause organ
cause
damage.
brain damage.
Yes.
So continuously, if you are seeing first time when you saw the saturation
Yes,
was
very
low.
low.
Okay.
Yes, sir.
Normally, any seizure patient, if you manage, you can see that initially saturation will be low. If you are persistently having seizures, then your oxygen carrying, not oxygen saturation in the blood will slowly come down. Then the brain will not get adequate oxygen. It will suffer because of hypoxemia. Okay. So that patients can develop permanent brain damage. To avoid that, you are starting oxygen, you are stopping seizure. So you have to completely paralyze the patient. That is very, very important. Okay. So this patient has recovered. Any other things you want to check in this patient? So you have to advise the patient properly.
Yes.
So that is very important. When you are giving anti-epileptic drug, make sure that patient is taking it properly.
Yes.
And avoid triggers. And if one drug fails, like you have one drug in a maximal dose, if that is not giving adequate control, you have to add another drug. Okay. That's why drug levels are very, very important in management of seizure activity. Okay. So we don't do any CT scan. We can discharge this patient. Can we discharge?
First, we'll have to give him advice on.
Okay. So you have to counsel him properly to avoid such conditions in the future, and we can discharge in 1 or 2 days.
Yes.
Okay. Okay.
Yes.
Thank you.